Good morning, good afternoon, or good evening to all of you who have joined this very interesting webinar today, ACARE LevelUp webinar on understanding the dynamics of triggers and prodromes in hereditary angioedema. I'm Dr. Ankur Jindal, and with me we have three experts who will be delivering lectures on this subject. We have Dr. Teresa Caballero from Spain, Dr. Avner Reshef from Israel, and Dr. Robin Lochbaum from Germany. The learning objective for this webinar would be to understand the potential triggers for flare-ups in patients with HAE and how to avoid them. To also recognize the emerging concepts behind the prodromes in hereditary angioedema, and to identify triggers prodromes in patients with HAE that influence disease progression. And we'll also get to learn about how these prodromes are changing in the era of modern prophylactic treatment options in patients with HAE. So as I said, there will be three talks, the current concepts behind triggers in patient with HAE, how to identify, how to manage. We're going to talk about prodromes, clinical implications and identification, and the changes in prodromal signs in patients during the use of modern long-term prophylaxis. So this is truly an international webinar, representation from all continents, different countries in the world, more than 90 registered users from more than 38 countries, and I'm very happy to see the maximum number of registrations are from India as compared to any other country. So really good news for me. So we have CME accreditation for this webinar, and I would request you to fill the feedback form at the end of the webinars to get the CME accreditation. And this will be the survey at the end of the webinar. To get the CME point, you will have to scan this QR code, complete the survey, and you will be able to get the CME credit point. So we'll have three talks in continuation, and we'll have approximately 10 minutes at the end of the three talks to take up questions, to have discussion, to take up comments related to these three talks. So I would request you to leave your comments and questions in the Q box or the chat box on the Zoom window, and we will make sure that we address all of them at the end of these three talks. So to stay connected with ACARE on social media and website, use the scan and just stay connected with us on social media and websites. So with this, we begin this very interesting webinar on understanding dynamics of triggers and prodromes in hereditary angioedema. And I'll stop sharing my screen, and I would hand over the stage to Dr. Teresa to present her lecture. Over to you, Dr. Teresa.
Well, first of all, I would like to thank ACARE for inviting me to participate in this Level Up seminar that I think that they are really interesting in improve the management of patients with HAE. These are my disclosures. There are a lot of manuscripts that speak about the triggers or the desencadenant precipitating factors for angioedema attacks, and I am only presenting some of these manuscripts. In year 2029, Dr. Bigun from Denmark published in the British Journal of Dermatology a complete description of the patients with HAE in Denmark and the precipitating factors. And they describe the suspected precipitating factors for the first attack of every patient. And then they found that dental treatment, the pregnancy, porphyrium, estrogen-containing contraceptives, trauma, and stressful or exciting situations such as examinations, birthday, Christmas, or starting in the kindergarten were some of the precipitating factors for the first attack in their case series. They reported that nearly 94% of the patients describe a precipitating factor in at least one of their angioedema attacks, and these precipitating factors were mainly trauma, emotional stress, medical or dental procedures, menstruation, estrogen-containing drugs, and angiotensin converting enzyme inhibitors. So they really say a sentence that I think is very clarifying, that the really precipitating factors can be clues to the diagnosis in these patients, because really they show that patients with precipitating factors had a smaller delay in diagnosis than patients without such precipitating factors. In the IOS, the Cativan Outcome Survey Registry, we studied also triggers of attacks, and we studied triggers during historical attacks before the patient being recruited for the study, and emotional distress was really the most frequent and the precipitating factor, followed by physical trauma, infections, and others are changes in estrogen levels, medications, exposure to cold temperatures, prolonged sitting or standing. And then we also uh, took into account those triggers after enrollment into the registry. And then emotional distress was also the most frequent trigger for if you will take into account attacks or patients. Um, we will see later how we can manage this. There have been several publications about triggers in children, and this is a publication by the group of Henriette Farkas in Hungary, and then describe a series of 26 pediatric patients, 15 females, and for them, trauma, infection, stress, and menstruation were the most important trigger factors, being trauma most frequent than the stress in the pediatric population. That is different to the adult population. In another study with pediatric patients and adolescents in Iran, and they describe as attack triggers food, trauma, stress, and infection. And then they showed that the delay in diagnosis was really higher in those patients without any attack trigger. In this other publication, that is a review about hereditary angioedema, co-authored by Paula Bush and Sandra Christiansen, they compare the triggers between different types of angioedema. Well, in HAE due to C1 inhibitor deficiency, they describe that the attacks are often unpredictable, but stress, trauma, infection, estrogen, and fatigue can be the main precipitating factors. In HAE with normal C1 inhibitor, the attacks are also often unpredictable, and stress, trauma, infection, estrogen, fatigue are the same triggers, but the influence of estrogens is much greater in HAE due to F mutation in factor 12 than in HAE without a known mutation. In idiopathic and non-histaminergic angioedema, there was no trigger described at that time. And in acquired C1 inhibitor deficiency, they say that the number of attacks can be affected by the underlying disorder, and they are also like in HAE due to C1 inhibitor, stress, trauma, infection, estrogens, and fatigue. And in ACE-induced angioedema, ACE inhibitors for sure are the precipitating factors, but not angiotensin receptor blockers. And this is very, very important because these are a very important alternative for patients with arterial hypertension. How can we manage these precipitating factors? Well, we can avoid them, and this was really the strategy that was done 30 years ago. We tried to avoid everything. We tried to avoid trauma. We advised children not to play contact sports, but we will see that now we have other strategies to do this. We advise the patients not to take estrogens, oral contraceptives, hormonal replacement therapy, and so on. We should try to treat bacterial infections as soon as possible. Well, there was even a study that in patients with many abdominal attacks, Helicobacter pylori infection was very frequent, and so if treated, the patients had fewer abdominal attacks. This was a first publication in Lancet, but later there was another publication that didn't confirm these results. But we can also use short-term prophylaxis. For example, we are not avoiding a surgical intervention. We are not avoiding dental extraction or endodoncy. And so we have this another approach. And also long-term prophylaxis can help to manage these situations and not having to avoid all the precipitating factors. So now we have a consensus on the treatment goals in hereditary angioedema that we reach through a Delphi consensus. And then the main objectives are the total control of the disease and to normalize the patient's life. And we cannot normalize the patient's life if we advise them to avoid everything. So this strategy was adopted by the last international WOW-EACI guideline for the management of hereditary angioedema in the 13th recommendation, that we recommend that the goals of treatment are to achieve total control of the disease and to normalize patients' lives, with 100% of agreement, although evidence level was low. So we come now to speak about short-term prophylaxis, also known as pre-procedural prophylaxis. And this treatment is used to reduce the risk of angioedema attacks in HA patients before specific procedures or events. And the aims are to prevent or minimize symptoms before situations that may trigger an attack, such as surgery, dental procedures, or stressful events. And here we started to introduce short-term prophylaxis, for example, for exams, weddings, any other situation that could precipitate an angioedema attack, but weren't an medical intervention. And the medications that we use for short-term prophylaxis, the election treatment is intravenous plasma-derived human C1 inhibitor that 1 to 6 hours before the procedure and as close to the procedure as possible. And we have 2 different brands that we can use either. And the second line treatments for those countries in which plasma-derived C1 inhibitor is not available would be danazol or tranexamic acid, although we have less evidence about this. Really, short-term prophylaxis is crucial to minimize the morbidity and mortality of angioedema attacks, especially in the case of upper airway involvement, which can lead to asphyxiation. And this was importantly shown by Conrad Bohr in a series of patients with that suffer dental extractions, and he showed very well that short-term prophylaxis avoid a lot of these angioedema attacks after dental extractions. But we also have another strategy that is long-term prophylaxis. And as an example, I will speak about a recent paper by the Berlin group in which they expose the management of patients with HAE and acquired angioedema due to C1 inhibitor deficiency with long-term prophylaxis with lanadelumab. And then they show the results of 34 patients that initiated long-term prophylaxis with lanadelumab between February 2019 and April 2020. And then 30 patients had their hereditary form for the acquired form of C1 inhibitor deficiency. And then, among other things, they assess the use of short-term prophylaxis and the medical procedures that could induce angioedema attacks. No angioedema occurred after 146 out of 147 potentially attack-inducing medical procedures that were performed without short-term prophylaxis, and this was referred by 22 patients of those included in the study. And really, although the patients had access to C1 inhibitor, they decided not to use it. And then, here we can see the medical procedures that were tooth extraction, dental implant, dental cleaning, periodontal disease prevention, root canal treatment, drilling and filling of teeth, other dental measures, ENT procedures, intubation, and gastroscopies. And they only had one patient that had swelling of the mouth and neck after the extraction of 4 teeth without the short-term prophylaxis, and another patient that had performed 24 tattoos, and 21 of these tattoos were done before the start of lanadelumab and had angioedema, and 3 tattoos were done during treatment with lanadelumab, and the patient didn't have angioedema in any of these 3 tattoos. And this patient also had 2 piercings, one before lanadelumab with angioedema development, and another one after lanadelumab without angioedema. Then I would like to conclude my presentation by saying that really precipitating factors can be a clue for the diagnosis of patients, that avoiding triggers is one of the management strategies, but short-term prophylaxis is another strategy, with plasma-derived C1 inhibitor being the election treatment, but also effective long-term prophylaxis with the sample of lanadelumab, but could be also other drugs like sub-Q plasma-derived C1 inhibitor, could make short-term prophylaxis unnecessary, but really more studies are needed before we can advise patients not to use short-term prophylaxis between these procedures. And thank you for your attention.
Thank you, Dr. Teresa, for this very informative talk. We will take up questions at the end of all three talks. I would encourage all the participants to please post your questions in the Q&A box. Now we move on to the next presentation by Dr. Avner Reshef. Very interesting topic about prodromes in patient with HAE, clinical implications, and how does one identify prodromes. Over to you, Dr. Avner. Dr. Avner, need to unmute.
Good morning, good afternoon for whoever listens to our discussion here. I was invited, and I of course thank the organizers for inviting me. And today I'm going to talk about some enigmatic phenomenon in angioedema, which is prodromes. Next slide. This is my disclosures. And as a background, prodromes are premonitory signs and symptoms that has been observed in association with HAE attacks, which means that it might be also a premonition. Premonition means some kind of an idea that patients are having. But in this case, we are not talking only about premonitions, but also all kinds of physical and psychological signs and symptoms that precede the attacks. The clinical significance of prodromes has not been investigated in depth and in systematic manner. And we devised a couple of years ago a new tool, an instrument based on patient reported outcome, PROs, that was aiming to look at the prodromes and attacks and see if there's an association between them, and to check if prodromes can actually predict an attack using predefined variables. Next, please. But talking about prodromes, let's keep in mind that many years ago, more than 140 years ago, Sir William Osler, Sir William Osler described in 1888 a patient with swelling attack in a red and marble condition of the skin of the breast, which is probably the first description of a prodrome associated with a swelling attack. And at that time, Sir William Osler called this condition angioneurotic edema. And I hope that none of you will use this term because it's not neurotic condition. It's a physical condition. And let's leave this very old term behind. 75 years later, Dr. Nathaniel Lenderman, who was the first to describe a series of patients with HAE, asserted that he could distinguish between types of angioedema, such as allergic, non-allergic, and asserted that prodrome is preceding attacks of hereditary angioedema only. Next, please. So the definition of prodromes entered into the new classification that has been published last year in JACI. And as you can see here, statement number 3 is saying that prodromes are characterized by sign or symptom often indicating impending onset of attack. It's manifested subjectively, such as pain, tingling, anxiety, and all sorts of subjective emotions, and also objectively by skin rash, for example, erythema marginatum, flushing, diarrhea, and all kinds of other physical signs and symptoms. Prodromes typically occurred between 1 and 12 hours before attack. we had to limit the reports to 12 hours because some patients are telling us about all kinds of phenomena that starts even 3 days before the attacks. So we decided to limit it to 12 hours before the attack. And the interesting thing is that prodromes can reiterate in the same manner, and this allows the patient to predict possible onset of oncoming attacks. Next. So in 25 years ago, Ramada from Tim Craig's group in the US noted that 96% of the patients that they were having in their site were reporting prodromal symptoms. And 91% of these patients say that they are able to predict the onset of at least some of their acute attacks. You can see it on the right-hand panel, how many patients associated the attacks with prodromes. When the patients were asked, are you able to predict the onset of an attack? Most of them said yes. Later on, we did three separate studies and asked patients in our country and in the US, and found out that between 82 to 95% of the patients answered the question, are you able to predict the onset of an attack by a prodrome? And answered yes. Okay, next one. And this is this is the same slide that Teresa has shown you previously, taken from the IOS, from the icatibant observation study, showing that prodromal symptoms are quite frequent. In the history, patients noted that they had prodromes before on the left-hand side, and right-hand side, you can see that even after being enrolled into the study, patients were receiving icatibant for acute attacks, but they still evaluated that prodromes are very, very frequent. Up to 70% of the patients from 359 attacks had prodromal symptoms. Next. This slide was taken from my associate, Dr. Iris Leibovich, and we looked at the association between attacks and prodromes, and you can see that we looked at clusters or body locations. In the abdomen, for example, you can see that if you look at the specificity and sensitivity, you can see that the specificity of having a prodrome before an attack in the abdomen was 99%, and the sensitivity was close to 60%. And this goes to urogenital system, facial, extremities, and oropharyngeal. Actually, if you look down the last row, you see that oropharyngeal attacks were associated with prodromes, and the specificity of these two is 98%. Next slide, please. And this was taken from our publications back 2-3 years ago. You can see that if you look at the left-hand panel, you see the evaluation by the patients using a Likert scale of between 0 and 10. You can see that the intensity of the prodrome is, of course, less than the intensity of the attack. Look at for example, pain. The pain in the abdomen was evaluated at 7.8, but the prodrome was also was associated with quite high perception by the patients. And on the right-hand panel, you can see the Pearson correlation, and you can see that attacks and prodromes are quite correlated when you look at the abdominal area, the abdominal region, or attacks. Next one. So this is the conclusion that we had in one of our publications. Prodromes are frequently reported, and many of our patients intuitively use them to predict oncoming attacks. And by using the new instrument, we were able to conceptualize, define, and characterize the prodromes. And that was a scientific tool that we are quite happy to suggest to other investigators. If you want to use this instrument, it's already translated into English. It's built, as I mentioned before, on questionnaires or patient-reported outcomes. The third point is that the association between attacks and prodromes emphasize that prodromes has a predictive value to indicate oncoming attacks. And we also believe that recognition of prodromes can alert the patients to become conscious about what's coming on and what to use if an attack ensues. We also think that a simulation prodrome diagnostic tool into clinical practice may guide clinical decision-making and management. Next. This is an evidence, it's interesting evidence taken from a paper published about 20 years ago, showing that if you take the skin of patients with erythema marginatum, you can find some traces of bradykinin in the skin. And this is very important because it makes you think that maybe the attack starts very early. Maybe the bradykinin surge starts before the clinical signs are obvious. Next slide. To support this, Nora Vesely from Henriette Farkash's group studied one patient and studied the kinetics of C1 inhibitor and C4 in a silent period, which is about 42 hours before an attack started, and then during the prodrome, and later on during an attack. And you can see that a C4 depletion started at the prodromal phase and progressed, reaching the lowest level after the maximal attack severity peak. And also C4A was 4 times higher, 7 hours before the onset of the attack. This may mean that, and this is a diagram I drew just to look at the dynamics of this phenomena. If you look from left to right, you can see that a prodrome probably exhibits the start of the contact KKS activation, and the vascular endothelium starts to open up. During an attack, there's a hyperpermeability. You can look at the clinical severity on this slide. And then the cadherin junctions are closing down, and the attack is ending. So we think that prodrome is part of the attack, and prodromes should be investigated more thoroughly, maybe to understand how these attacks are developing. Next slide. And the next question is, of course, is it the time for prodromes, that the time of prodromes is over? Because you just hinted that using lanadelumab or other prophylactic measures can reduce the risk for acute attacks. So just to give you an example, this is a very, very recent study by Hilary Longhurst and her associates, looking at systematic review of 2,800 randomized controlled trials, non-randomized, interventional, open label, and they picked up 58 publications describing 45 primary studies published from January 2002 and May 23. And look here, on-demand therapy was used between 49 to 94% of attacks, occurring in the presence of long-term prophylaxis. Laryngeal attacks accounted for 2 to 7% of all attacks in observational interventionals, regardless of the LTP agent. Patients receiving LTP still experience attacks in all anatomic locations, including the larynx, and most attacks were treated with on-demand therapy, although outcomes were not reported. So the authors are summarizing this huge systematic review by saying that access to on-demand treatment remains essential for all people with HAE C1 inhibitor. So next slide. To summarize, albeit frequently reported by the patients, prodromes have not been adequately investigated, and there are few systematic tools. Next, recent observations suggest that studying the very early phase of the attacks will allow better insight on angioedema pathogenesis. And also, accurate prodrome assessment is critical for early diagnosis of attacks and timing of medical interventions, since effective drugs are available for self-treatment. So if the patients can identify the oncoming attack by having a prodrome, it's very important to make them ready for any kind of intervention to prevent the progression of the attack. Thank you.
Hey, thank you, Dr. Avner. This was very informative, very elaborate, and very, very interesting observations. We already have a couple of very interesting questions which we'll be taking after the third talk, and I would encourage all the participants to please keep posting your questions. And after the third lecture, which is understanding prodromes in the era of long-term prophylaxis, by Dr. Robin Lochbaum. Over to you, Dr. Robin.
So thank you very much. Can you see my screen? Does it work?
Yes,
Perfect.
it works.
So hello to all over the world. Thank you very much to ACARE to invite me for this very interesting session. I will close the webinar with a topic about changes in prodromal signs in patients during the use of modern LTP. Just in the beginning, my disclosures. And I want to start a little bit in the fundamental part. I think Dr. Reshef made a great introduction for my talk. As you all know, hereditary angioedema occurs episodically. So patients have a longer or even also shorter so-called attack-free state. I think we all know that even in this so-called attack-free state, patients had a lot of especially psychological problems, but this won't be the focus on my talk. I will focus on the part prodrome and angioedema. We heard about prodromal symptoms. They can range through a variety for different symptoms, from dysesthesia, gastrointestinal complaints, tiredness, changes in mood, and restriction in concentration, and also the annular non-itching rush, the so-called erythema marginatum. As we heard, they can occur before an angioedema and affect the majority of HAE patients. I always think when I hear about those symptoms, tiredness, changes in mood, they're a little bit unspecific, but during the course of the disease, many patients get to know their personal prodromal symptoms and know that these are their specific warning signs. And so, as Dr. Reshef said, they can be used as a predictor of an oncoming attack, especially for acute treatment. To visualize this, I have 4 scenarios when the acute treatment is applied. As you can see on the upper left side, the acute therapy is applied during the maximum of the attack. Then perhaps you can stop the ongoing of the attack, but the time to resolution is quite long. Also, on the lower left scenario, you see ongoing of the attack can be stopped, but time to resolution is already quite long. The upper right scenario shows when you administer the acute therapy at the very beginning of the attack, there you have an effective answer on the acute treatment, and the maximum is when you apply the acute therapy when the prodromal symptoms is already there, then no attack could even occur. And I think this is also mentioned in the WAO EACI guideline, the recommendation 6, where they stated that it's recommended that attacks are treated as early as possible. And here, prodromal signs can be a useful warning sign for our patients. So now I talked about the relevance of prodromal symptoms to acute therapy. What about the other two pillars of HAE treatment? And when you look at short-term prophylaxis, I think there is no direct or clear impact on prodromal symptoms. And if we look to long-term prophylaxis, we have the problem that we have a lack of data. We don't know quite what is the impact of long-term prophylaxis on prodromal signs. It could be that there's an impact on frequency and severity. It could even be that there's an impact on the type of prodromal symptoms, which would be not that good for our patients because they could potentially lose their early warning capability. And it could also be that it has no impact on it. We first performed literature research, and we wanted to look for clinical trials or even better randomized controlled trials. And we saw that the most clinical trials don't even look for prodromal symptoms. We also checked for the major long-term prophylactic treatments and their clinical studies. And even here, prodromal symptoms were not thoroughly investigated or not mentioned in the publications. So we thought we have to do it ourselves and get a little bit more light into these questions and perform the study in our ACARE center in Ulm University. We did a questionnaire-based analysis and could include 26 patients with HAE, which were undergoing modern long-term prophylaxis, and assessed especially their prodromal symptoms. Just a quick overview about our study population. We had a little bit more female patients than male patients. Most of them were between the age of 30 and 60. As you see on the right side, the type of long-term prophylaxis, we have a huge amount of patients with lanadelumab subcutaneously, followed by berotralstat orally and C1 esterase inhibitor derivatives. And I want to state that this high amount of lanadelumab could, of course, be a bias for our analysis. We then asked the patients, did they ever had any prodromal signs? And you see only one patient said that he never experienced a prodromal sign. Most patients did. The most mentioned was erythema marginatum, followed by tiredness, dysesthesia, and gastrointestinal complaints. And then we asked the, for us, most important question, was there any change in the type of the prodromal sign? And for us, very good. There was no impact on the type of prodromal symptoms. So the patients, they have their already known trigger indicators, and so they know again which is a prodromal sign and which not. But we thought there could be an impact on the frequency and severity of the prodromal symptoms as it is on the breakthrough attacks. And we could show that over 50% of the patients which reported prodromal symptoms in the beginning stated that there weren't any prodromal symptoms since the initiation of modern long-term prophylaxis. Another third said that it was weaker. There was only one female patient which stated that her tiredness was stronger under long-term prophylactic treatment, but without a desire to change or stop long-term prophylactic treatment. We then wanted to look if there were specific prodromal signs which were higher impacted by long-term prophylactic treatment. And as you can see here, this was the case for two, erythema marginatum and gastrointestinal complaints. To speculate about this, you can say that erythema marginatum is kind of the most objective prodromal sign. So you know, okay, if you have this rush, it's belonging to my HAE. Tiredness, changes in mood, and the other symptoms can have a variety of reasons why they occur. And it's very clear if you have it or not. And so we can think that this is one possible explanation why erythema marginatum is that highly impacted by long-term prophylaxis. Regarding the gastrointestinal complaints, Dr. Reshef already said that you can distinguish between the prodromal gastrointestinal complaint and an acute abdominal attack. But sometimes it could be that it's a little bit difficult to handle for the patients, and sometimes they say, okay, it's perhaps it's a gastrointestinal complaint as a prodromal symptom, even though it was a slight abdominal attack, and perhaps this could be one reason why this symptom is that highly affected by long-term prophylaxis. But you have to keep in mind this is all speculation since we lack more data about it. Last but not least, we wanted to look what is then the impact of long-term prophylaxis about the handling of prodromal symptoms in our patient cohort. And so we asked them before they initiated long-term prophylaxis, did they apply their acute treatment when a prodromal symptom occurred? And you can see on the left side that nearly a third of all patients said, yes, I applied my acute therapy as the prodromal sign occurred. After the initiation of long-term prophylaxis, in total, less patients answered this question because that many didn't experience any prodromal symptoms anymore. And you can see here only one patient said, yes, I applied my acute therapy when a prodromal sign occurred. The other patients were much more relaxed and said, well, let's have a look what comes. I will wait. Due to health economic reasons, this is a good news. These are good news, but I think you have to keep in mind what comes after the prodromal sign. And we asked the patient, was there a breakthrough attack after a prodromal symptom? And yes, nearly 50% reported that there was a breakthrough attack even under long-term prophylaxis. And we also asked for the severity, and there 2/3 said the intensity was between moderate and heavy. And so this this could have been not occurred when they had applied their acute therapy as the prodromal sign occurred. So you have to keep this in mind. To sum this all up, I hope I could show you that prodromal symptoms are an important warning signs for impending attacks and can enable early intervention with acute therapy. When you look about the impact of long-term prophylaxis, we could show that the frequency drops, but the characteristics remain unchanged. So the patients have a persistence of their valuable early indicator markers. And in our cohort, we could show that the usage of acute therapy decreases under long-term prophylaxis when a prodromal sign occurred. But keep in mind, attacks continue to occur after the prodromal symptoms. And so it's always important to tell the patients acute therapy should be in close proximity when a prodromal sign occurs. Now I'm at the end of my talk, and thank you very much.
Thank you, Dr. Robin. This was very, very interesting, concise, very informative. So we have exact 10 minutes to have the discussion. We already have a couple of very interesting questions. So the first two for Dr. Teresa. Can food induce HAE attack? Some patients think so. And is there any data on whether patients with angioedema delay or avoid dental procedures due to fear of triggering an attack? So first question on about food as a trigger for HAE. What's your thoughts? You need to unmute, Dr. Teresa.
Sorry. Well, I think that there are really no study about food as a precipitating factor. In my experience, some patients say that when they take a very heavy lunch or dinner, they can have an abdominal attack later. So not because an allergy, not because of food allergy, because really food allergy can occur in patients with HAE as well as in any other people. But I think that it could be related with that. And also some patients say that when they take too much alcohol, when they go out in the night, they can have an attack at the day after. But really, I think that there should be more studies about this.
Yeah, and I think no food really need to be avoided by
No, no,
patients with
no.
HAE.
We don't
There is no,
advise to
yeah,
avoid anything to the
absolutely.
patients.
Uh,
No.
agree, totally agree with you. The next question is also to you about whether patients with angioedema delay or avoid dental procedures due to fear of triggering an attack. Are there any data on this?
Yes. Well, I don't know really about publications about this,
Hmm.
but also in my experience, for example, the patients had very bad oral health because they delayed going to the dentist
Hmm.
because they have some relative that had, for example, had a very severe upper airway attack after tooth extraction or even had died. But then many years ago, when access to acute therapy was not so good. I think that now they are not avoiding so many procedures, but curiously in HAQual, we are the developers of HAQual, and one of the questions of the questionnaire is regarding the avoidance of medical procedures due to fear of angioedema attacks. So I think that this really is an important issue for the patients, but
Yeah.
really with the greater availability of drugs, not only for acute on-demand treatment, but also for long-term prophylaxis and short-term prophylaxis, these patients are not so afraid as before.
Hmm. Yeah, I totally agree. Like in countries where these drugs are not easily available, we still see patients who tend to avoid a procedure, especially a dental procedure. But I'm sure in countries where these drugs are easily available and accessible, I mean, this is not really an issue with the patients as of now. Well, the third one is, I think, more of a comment. The fourth is there any study that compares the number of attacks in patients with angioedema after medical procedures, both with and without prophylactic treatment? So,
Mhm.
uh, yeah.
Yeah,
Mhm.
yes, there are some studies that compare that. Really, there are some procedures that even if you don't have long-term prophylaxis, neither short-term prophylaxis, the patients don't develop an angioedema attack, and other procedures they do, and they compare if they did short-term prophylaxis with plasma-derived C1 inhibitor or danazol or tranexamic acid, and really if the patients do prophylaxis mainly with plasma-derived intravenous plasma-derived C1 inhibitor, there are fewer attacks. And
Mhm.
the two more important studies are published by Konrad Borg et al. And by Henrik Farkas et al. And I think that there is another one by MLI Goren Person, and it is clear that really short-term prophylaxis is good for preventing angioedema attacks after medical procedures.
Mhm.
Although there is only one clinical trial, the clinical trial with it's in RISE for long-term prophylaxis. They also study the procedures, the medical procedures that occurred during the clinical trial, and they administer C1 inhibitors in RISE before, and they demonstrated that it was beneficial, that they prevented angioedema, the development of angioedema attacks.
Yeah, perfect. Thank you. We have two more questions, both related to prodromes. One is there any established criteria to define a prodrome, including the time, minutes, hours, and other relevant factors? And can
Yes.
we include prodromes in the decision for long-term prophylaxis, Dr. Avner? Yes.
Okay, let me answer this. First of all, there are some established criteria, but unfortunately, um, our study, for example, used very strict criteria, and we try to avoid psychological inputs by the patients because patients vary by their concept, perception, etc., etc. We use either physical or items that can be identified and are common to not only one person, but for many patients in common. Unfortunately, our study is one of very, very few that was trying to establish criteria. And the only thing that I can suggest is that to have more people using the instrument that was already validated. And of course, in terms of time, I already pointed out that we are considering prodromes that starts um, between 1 hour to 12 hours, no more. And other factors are, of course, relevant. But I think that even in the area of prophylactic treatment, and as I showed you in the study, the recent study by the study about still having breakthrough attacks in patients on long-term prophylaxis, I think that the question of a prodrome predicting attacks is still very important. But there's a long way between this and some kind of a prodrome triggered treatment. Okay, we don't have any instructions for patients to start to treat themselves before the signs and symptoms are actually obvious. Of course, we do have patients who inject themselves before they go to work or to give a lecture because they are afraid of having an attack during their assignments. But to answer the question, there are some established criteria, but they are not shared by the whole community. And I wish we could come up with more consensus about this phenomena.
Yeah, I think it's important that we come up with a standard definition or some consensus on what is a prodrome, how do we actually define it. So it's very important. I don't see any other questions in the chat box, but one question to Dr. Robin. Do you think? You in your observation, you showed that patients who are on effective first line long term prophylactic treatment, the frequency of prodrome reduces, the characteristics do not. Do you think that the same phenomena may apply to patients who are not on the first line long term prophylactic treatment, but the second line long term prophylactic treatments in countries where none of the first line long term prophylactic treatments are available, such as androgens and tranexamic acid? Mhm.
So as Dr. Reshef showed, it's thought that prodromal signs also are due to increased bradykinin, and therefore it could be that also there's just a change in the frequency and severity, but not in the type. But far as I know, we don't have studies, and so I also
Yeah.
agree that we need more data. Even if you look at the guidelines, for example, of the WAO IACI, I think only on 3 times the word prodromal symptom is mentioned. And so I think this is a open medical need in HAE.
Mhm. Right. And I think there are no more questions. So one last question to, I think all the experts, in terms of triggers and in terms of prodromes, when do you counsel your patient to take treatment? Like when do you say that, okay, this is the time, before the onset of an attack? If you see this prodrome, you take the treatment. Or if you can identify a definite trigger that, okay, for example, in females, menstruation acting as a trigger and the patient is not on long-term prophylaxis, do you recommend taking some form of treatment during definite triggers in your patients? So to all of you.
Okay, well, I recommend my patients to treat attacks as soon as possible, but when they recognize an attack. For short-term prophylaxis, I recommend patients if, for example, they are having an exam and they can took the medication, the short-term prophylaxis to do
Right.
properly the exam, so, or the wedding, for example. I recommend them to administer plasma derivation 1 inhibitor before the wedding because really the patients are very afraid of having a facial angioedema during that very special event. So I think that we have advanced in advising this as soon as we have had the drugs more available. But when with the access to plasma derived C1 inhibitor was not so easy, we advised them to use danazol for a short time. For example, when they traveled and they were afraid if they traveled to a country where there was nothing and they couldn't also bring with them many years ago. We advised the patients for a short cycle of danazol, for example. So I think now we advise them to administer the intravenous C1 inhibitor, but then we advise them to use the attenuated androgen. So I think that is in some cases is much better to do the prophylaxis than to have an angioedema attack.
Right.
If I am allowed to add something from my experience, short-term prophylaxis has a very, very serious drawback because it's intravenous treatment, and dentists do not easily participate or collaborate with the giving IV injections. So the patient has to go to the regular physician or to a point of care to get the IV treatment and then go to the dentist. And sometimes it's a big hurdle. And many patients are actually avoiding short-term prophylaxis just because of the bureaucracy and the problem of getting an IV injection 1 hour, half an hour before the treatment. Treatments are usually scheduled, but the problems that, or at least the feedback I'm getting from my patient is that in many cases it's almost impossible to apply it.
What about your experience with the prodrome? So which is the prodrome and which is the patient group where you would advise them to take some form of prophylaxis during prodrome? So any particular situation, any particular patient, a patient who is more symptomatic, or a particular prodrome, what are your experience with advising treatment during prodromes?
Well, it depends on the experience. Experienced patients, in most cases, know their body and have more or less consistent kind of practical experience. So these patients, we can discuss with them if the same sensation, for example, a pressure on the limb, on the hand, or pressure on the abdomen, pressure comes again and again and precedes the attacks, we usually say, okay, if you feel that this is consistent and you know that there's a 50% of chance that an attack will ensue after such a sensation, okay, go ahead and inject yourself early just to avoid the progression of the attack.
Right. Um, Any comment from Dr. Robin? You want to?
I think you should distinguish between the trigger factors and the prodromal signs. I think if you have a patient which has a problem every time when it's, for example, menstruation, when a girl has very high problems every time a menstruation came, she has hard abdominal attacks. I think then it's better to introduce when you have it, for example, in Germany, to introduce long-term prophylactic treatment rather than always taking a short-term prophylaxis or acute treatment. When you look at the prodromal signs, I think there are no recommendation about just inducing long-term prophylaxis due to prodromal signs. I think there the acute therapy and the early treatment is much more important than during the trigger factors.
Mhm. Right. So yeah, I agree, and I think we have overstepped the time, and we've come to the end of this webinar, which was very very interesting on this subject, which has we've been able to clarify a lot of our doubts, but I think there are a lot of unanswered questions. Focus of research, focus of developing consensus that still remains. I think we had a very very interesting webinar, and this brings us to the end of this webinar, and I really thank all the speakers who participated, gave their inputs, and interacted in this discussion. To all the participants, please remember to complete this feedback form using the QR code QR code given over here, and to earn the CME point. So we stay tuned for more webinars coming up. We have the next one on July 10th. This is on understanding comorbidities in HAE, including risk of thrombosis and autoimmunity, a topic which is usually left untouched, not really talked about. A lot of questions about this subject. I think there are still a lot of unanswered aspects of this particular entity. So I would encourage you to participate in this particular webinar. This would be moderated by Dr. Thomas Budgrey from Berlin, Germany. And stay connected with us, ACARE, on social media and website. Use this QR code to stay connected with us. And with this, I wish to thank all the participants, all the speakers, ACARE for giving us this opportunity today, all our sponsors, and the ACARE team working from the behind, Rebecca and Isabella, and coordinating everything. So we see you next in the next webinar. Till then, stay safe and have a good day. Thank you so much.
You're welcome. Bye.
Thank you very much.
Thank you.
Goodbye.
Bye-bye. Bye-bye.
Bye, everybody.
Thank you. Bye.